So looking at our laundry list here, remembering those normal peds ranges. So unfortunately, that is just a memorization thing. I don't necessarily know any particular tricks off the top of my head that help you to remember those. It's just a matter of memorizing and using those critical thinking skills. We know all of our pediatric ranges are going to be lower than adult ranges. So kind of using that process of elimination and what we know for normal and abnormal. We are going to get ready for HESI this week. So our HESI exam, unfortunately, is not a lot of spitting out of facts. We're going to ask you to apply information to a clinical setting. We want to see those nursing skills put to use without putting a patient at risk. So we give you a written format of a clinical scenario. So that's kind of the baseline of our HESI. So as we're getting ready to take this HESI test, we've talked about this over and over. In order for information to make it into your long-term memory, you have to see it more than once. So make sure you're reviewing this information over and over again repeatedly, focusing on those areas where you're consistently struggling. As you are doing practice questions, don't just look at why the answer is right. Also look at why the other ones are wrong. You will start to notice trends in the way that questions and answers are phrased. And that will help you as you're doing that process of elimination on some of the more difficult questions. So look at why those answers are wrong, figure out any tips and tricks in there, anything that you start to notice consistently in the way that wrong answers are worded. Like we said, cramming is not going to be beneficial at this point. You've got to review that information so that it gets into your long-term memory so that you can actually apply that information to a clinical situation. Also, rereading your textbook cover to cover is not going to be sufficient for studying for this exam. You want to focus on your highlights, the notes that you've made, maybe any flashcards that you've done throughout the term to check your understanding. The only time I recommend rereading sections of your textbook is if you're noticing you're consistently struggling with a particular topic. So if you do a set of practice questions and you see that you missed every single one that you saw on atrial septal defects, then go ahead and reread the section in your textbook about atrial septal defects. Otherwise, at this point, rereading your textbook or going back and doing your readings for the entire term are not going to be helpful for you. Most importantly, the night before your exam, make sure you go to bed at a normal, decent hour, get a full night's sleep, make sure you eat well, stay hydrated, take care of yourselves so that you can put your best foot forward when you go into the exam. You don't want to stay up all night cramming and then go into the exam with a tired brain. That doesn't do anybody any good. When it comes to taking the test, try and keep a positive attitude. Don't let yourself get discouraged or anxious. Make sure you're not comparing yourself to your classmates. So don't ask, oh, did you study this? Did you study this? You're going to make yourself really nervous. Everybody needs to study different things based on where their strengths and weaknesses are. So it's okay if you didn't study the same things that your classmates did. Mother Nature is going to throw every wrench in your plan that she can as you are getting ready for HESI. So make sure to give yourself some extra time to get to campus and get yourself set up. Be prepared for things like flat tires, extra traffic, getting in your car and realizing you don't have enough gas to get to campus, your computer being dead when you get there. Anything that can go wrong will go wrong. So give yourself some extra time so that you're not super anxious and worked up before you take your exam. If you find anxiety creeping in, close your eyes and take a couple slow, deep breaths. That has been proven to reduce tension. So if you find yourself getting anxious or worked up or discouraged, then just close your eyes, take a couple deep breaths to refocus, and then continue on with your exam. When you get to those difficult questions, don't let them get you down. Don't get caught up in them. Don't spend a ton of time on them. We're going to teach you how to do process of elimination and how to make educated guesses when we don't know the answers. So just go through that process and then move on. Start fresh with the next question. You guys always finish early on your exams, so slow down, take your time, make sure you are reading your questions. You should read through an entire question, all of the answer choices, come up with your best guess, and then put that answer back into the question to make sure that that was what you intended to answer. You have plenty of time for that. I can guarantee you can do that on all of your questions and still have enough time. For your math questions, make sure you rely on those formulas so that you don't make silly mistakes. Work through those questions twice to make sure that you get the same answer both times as a way to double check yourself. And then make sure that you're paying attention to what the question is asking and you're answering in that correct format. When we give you matrix questions or questions that have multiple parts to them, so maybe a matrix question or a scenario question, make sure you didn't skip over something. When we have a long list of things, it's very easy to skip over an item. So before you hit submit, just double check and make sure that you didn't miss anything. And then everybody's question is whether or not to change an answer. So my rule of thumb is that you should not change your answer unless you 100% know beyond the shadow of a doubt that you picked the incorrect answer. So you read through, you picked your answer. When you put it back in the question, you're like, oh, I know that's wrong. That is the only time that I will tell you to change your answer. So you have to know beyond the shadow of a doubt that you 100% picked the wrong thing. Otherwise, go with your gut. It's probably telling you that answer for a reason. So now we're going to look at question types. So multiple choice is what we're all familiar with. That's what the majority of questions are. Like I said, when we were talking through taking the exam, read over the entire question, read over all of the options before we make any decisions, eliminate the options that you know are definitely wrong. Then look at the underlying subject matter. So what body system are we talking about? What disease process are we talking about? Then you can do another round of elimination and cross out anything that's not related to that underlying disease or body system. That should get you down to one, maybe two answers, and you'll be able to make your best guess from there. For these new next-gen style nursing questions, these are those clinical thinking skills that we're trying to assess. So make sure you read over all of the data in the case scenario. That's going to tell you about your patient. That's like your handoff report. Make sure that you don't skim over the data presented. There's important information in there. Then we're going to look at that underlying question format so we can determine what test taking strategies to use. And then once we have figured that out, we're going to rely on our clinical judgment skills, our nursing knowledge, and our clinical experience to determine what that correct answer is. So at that point, maybe you took care of one of these patients in clinicals. You can think about what you were expected to do for that patient, and that might help you to come up with the correct answer here. Our fill in the blank questions are typically going to be a medication dosage or an intake and output question. Make sure that you read all of the directions carefully, paying close attention to those units of measure. Pay close attention to things that look alike, like micrograms and milligrams. Make sure that you're not missing a conversion that you need to do. You can use your whiteboard or an on-screen calculator just like you do for exams. Make sure you read the question, figure out which formula you want to use, perform any conversions that you need to, double check your calculation, make sure to work through the problem twice. And then once you've come up with your answer, look back at the directions in the question and figure out if you need to round to a certain decimal place or if you need to answer in a whole number. Remember that we wait until the very, very, very end of the calculation to do any necessary rounding. For our dreaded select all that apply questions, a lot of these will ask you about what you would do first, what's most important, prioritizing care, putting steps in the correct order. These are going to be those select all that apply questions. So as we're prioritizing, we can look back at our ABCs. So airway, breathing, circulation. Those are always our top three. We can also look at Maslow's hierarchy of needs and the nursing process to help us put things in the correct order. Look for strategic words in your question. So is it the best intervention? Is it what you would do first? Also, is it a positive or a negative question? Are they asking what demonstrates correct understanding? That would be a positive question. Looking for what the correct answers are. Or is it a question that says needs further teaching? That would be a negative question type. We're looking for what the incorrect information is in those answers. Think about that underlying body system that we're talking about, what you know about it, what we're trying to ask of you in that particular question. Again, sometimes can be helpful to visualize a situation. So whether you've taken care of one of those patients or seen them in like a CJ Sim, you've heard about it, you've read about it somewhere. If you can tie it back to something you've experienced, sometimes that can be helpful. I caution you that you don't add information. I'm not sure. Sorry. Siri thought I was talking to her. So make sure that you're not adding to the question. It's easy to convince ourselves that every answer presented is correct because we start adding information to the question. So only use the information that's provided to you. And then think about those things that you do automatically without thinking when it comes to nursing. So before we can teach our patients anything, we have to make sure that they are ready to learn. We always wash our hands before we ever do any patient care. We explain something before we actually do it. We get informed consent before we do an invasive procedure. Those kind of no-brainer things. Remember to include those when you're doing your steps or prioritizing information. And then don't forget about documentation. Documentation is one of those things that we leave out, but remember, if we didn't document it, then we didn't do it. So that also has to be included as we're ordering steps in a procedure. For our scenario or exhibit questions, these are just like your CJ Sims. So same precipice here. We get a medical record. We ask you questions about that medical record. So we've got to read over the entire medical record to know what's going on with that patient. Again, avoid skimming that information. You're going to miss key points there. Then look at the subject of the question. What of that medical record applies to that question? What doesn't? So if we're talking about a neurologic status, our GI information probably not going to be super helpful to us. So we can automatically ignore that. We're going to focus on whether or not they're alert and oriented, how they're able to move. Do we notice any asymmetry in their expression or their movements? Look for those strategic words again in the question. Are they targeting a specific type of intervention? Are they trying to tell you what's best, what's first? Is it a positive or a negative question type? And then reread the data that applies to that question and then lean back on those clinical skills to determine what the correct answer is. So we have done all of these things, and we get to a question that no matter what strategy we use, we still have no idea what this question is talking about. We've never heard about it before. We have no clue where to start. So we have some additional strategies for those types of questions. Anytime you see an absolute, so words like always, never, must, or cure, that means there is no other option available, which we know is not how medicine works. We have individualized patient-centered care. Everybody reacts differently to interventions. So absolutes tend to be wrong answers. We know there are no instant cures for any of our conditions. So those will likely be incorrect answers. Like I talked about with visualization, don't read into the question. Use only the information that is provided in that question. You truly have everything that you need right there for you. As you're trying to order your steps or prioritize interventions, you want to start with least invasive first. So if I have the option of vital signs or starting an IV, vital signs is going to be least invasive. Also, it's going to be less scary for a pediatric patient. So we're going to start there before we do an invasive procedure. The other half to that is we always want to do assessments before we intervene. We need to know where the patient started before we started adding treatments in, so we know whether or not we were effective. The only time that is not true is if our patient is visibly in distress. So if I'm coming in to do an admissions assessment and my patient is blue and they are using every muscle in their body to try and breathe, if I do my whole admissions assessment before I deal with their respiratory distress, they're going to be dead by the time I'm done. So in that particular case, we are going to go ahead and place oxygen on that patient and stabilize their breathing before we do that admissions assessment, because we want our patient to survive long enough for us to complete that assessment. Our HESI and NCLEX both are safety exams. So whatever keeps your patient the most safe is what you are going to do first. Or if you skipped that object, whatever that answer was, what would happen to your patient? If it would cause the most amount of harm, that is definitely what you need to do first. Any answer, oh, sorry, skipped one. When you are doing that assessment, make sure you always start with your patient. So thinking back to that admissions assessment, walking in to see that blue patient, you want to make sure that you are looking at that patient directly. You don't need a monitor to tell you that they are having respiratory distress. You can see that by the fact that they are blue and they're using every muscle in their body to breathe. So start with your patient. They can tell you a lot just by looking at them. Then you can work your way back through your machines and your equipment. Same thing when we teach you how to assess an IV to make sure that that site is still patent. We tell you to start at the insertion site first, make sure you don't have any issues there. Then you're going to trace backwards up your tubing, making sure you didn't miss any clamps or rollers. Then look at your pump, make sure there's no issues. Then trace it back to your IV bag. So start at your patient, work your way back from there. Any answer that delays care is usually a wrong answer. So if we are in the middle of a med pass and the lab calls with critical value labs on one of our patients, any answer that doesn't immediately address those abnormal lab results is going to be wrong. So if one of those answers is continue on with your med pass, call the physician when you're done, you're delaying potentially life-saving care to that patient. So that's going to be a wrong choice there. Ideally, what we would do is stop where we are when we get that abnormal result and then call that physician, make sure that we don't have any changes that need to be made, address that patient with the critical lab results, then finish our med pass.
Yeah, can you give another example of a situation that delays care for a patient that you
Yeah.
wouldn't do?
Um, let's see. Delays of care. Um, if I was caring for multiple patients, and I had discharge teaching to complete, I had insulin to give, and I had a patient going to surgery. Which patient would come first here? So, first and foremost, our discharge teaching can wait. You're stable. Um, I guess that's not really a delay of care. That was a bad example. Let's think of another way that we could delay care. If we, I'm drawing a blank here. Um, oh, if we decided that we have 6 patients instead of our normal 4. So instead of coming and feeding our patient that has dysphagia, we take care of our 3 other patients first. We obviously have to be there to help that patient with dysphagia. They have difficulty swallowing, so they are unsafe to eat on their own. So by delaying care, we're putting that patient at risk. Does that help? Okay. Um, if we have 2 answer choices that are opposites, one of those is likely the correct answer. So if you're looking through your answer choices and you have a tachycardia and a bradycardia, we know one is fast heart rate, one is slow heart rate. One of those is likely the correct answer. On the other hand, if 2 of your answers are very similar, so if you saw bradycardia and low heart rate, there's no way for you to know what that test writer was thinking in that exact moment when they wrote that question. So you can automatically cross out both of those answers. Those 2 similar answers are likely distractors. So those are going to be incorrect answers. Also, if one part of an answer option is wrong, the entire answer is wrong. So if answer A has intervention 1, 2, 3, and 4 listed for answer A, in order for me to choose answer A, I need to do all 4 of those interventions. I can't pick and choose what I want out of that answer for answer A to be correct. So if I have a patient with hypotension, so low blood pressure, and answer A says notify the physician, administer fluids, give a beta blocker, and I don't know, what's another one? Increase salt intake. We'll just pull something random here. We know with low blood pressure, we wouldn't want to give a beta blocker. Also, our salt intake isn't really going to help our blood pressure at all. So because those 2 answers are wrong, all of option A has to be crossed out. We'll see an example of this in our Kahoots at some point today. Therapeutic communication questions are some of the easiest ones that you will see on the exam. So the whole purpose of therapeutic communication is assessing our patient's feelings by asking open-ended questions and restating what they told us to make sure that we understand correctly. So you will see a question stem that says, patient says X, Y, and Z. One of those answers will almost verbatim have X, Y, and Z in it. So you should be able to match what the patient said in the question to something very, very similar in the answer. By rephrasing exactly what they told us, we are making sure that we are understanding them correctly. Does anybody else have questions on test taking strategies? Okay, we are going to put these into practice with a case study here about cystic fibrosis. So this is one of those disease processes that we tend to struggle with on HESI. Remember, they love to test about respiratory conditions because they do affect a lot of our pediatric patients. So we are going to follow this kiddo all the way through their diagnosis through hospitalization. So parents bring their 2-year-old to a healthcare clinic to establish care with a primary healthcare provider. The child appears to be suffering from a cold and is experiencing rhinorrhea that is noted to be thick and tenacious, along with a dry cough, which the parent states began a couple days ago. The nurse suspects that the client may have cystic fibrosis. So, which assessments support that diagnosis of cystic fibrosis? So, what would we expect to see from our patients with that diagnosis? So, our weight loss and delayed growth, despite having a hearty appetite, would be consistent with cystic fibrosis. We know these patients suffer from pancreatic insufficiency and malabsorption, so that's what's going to cause the weight loss and delayed growth. If we saw that fever, swelling, and that productive cough, that can be more descriptive of things like viral pharyngitis, strep throat, or epiglottitis. Redness of the eyes is going to be more consistent with conjunctivitis. Yellow eyes can be a sign of a liver disorder. And that brassy cough with the inspiratory stridor. That inspiratory stridor should send off red flags in your brain that this could be croup or whooping cough. Our healthcare provider reviews the client's medical chart, which documentation further supports our diagnosis of cystic fibrosis. So looking at more signs and symptoms here. So our respiratory system is going to be affected by abnormally thick, sticky secretions that cause airway obstructions in our lungs. Other clinical manifestations of cystic fibrosis are poor growth and or weight loss, dry, non-productive cough, increased bleeding because we are deficient in vitamin K, one of our fat-soluble vitamins. Our white blood cell count is not affected directly by cystic fibrosis. If we saw an elevation in our white blood cell count, it would be caused by an infection that is causing a CF exacerbation, not because we have CF. We also don't typically see abdominal pain or periods of crying just because they have CF. And a sweat chloride level, we know that's the test that we use. Anything below 40 is considered a normal finding. So with a sweat chloride, the higher the number, the greater the indication of cystic fibrosis there. The term for undigested fat in the stool is steatorrhea. So because we've got undigested fat and protein, we get a nasty smell to our stool. They tend to be large and loose and sticky. So all that undigested nutrition gets excreted in our stool, giving us those bulky, loose stools. Our healthcare provider prescribes a sweat test to confirm the diagnosis of cystic fibrosis. What information should we include when teaching about the sweat test? Yep, this is a simple, reliable test that measures the chloride in the sweat. It's non-invasive, so we don't need consent. Usually takes about an hour. One test is usually all that we need unless we end up with borderline results. We may choose to repeat that test. But simple, painless, very reliable. We bundle that baby up really, really tight, make them hot and sweaty, and we use a piece of filter paper under their arm to collect a sample of that sweat. Then we can test that filter paper for the levels of sodium and chloride in it. And that has been our gold standard for diagnosing cystic fibrosis for over 40 years now. Our healthcare provider meets with the parents and informs them that the sweat chloride test results highly suggest the diagnosis of cystic fibrosis. Mom is very upset about the news and insists there's another explanation for the child's small stature, and some girls are just more petite than others. The father asks if there is another test to definitively confirm the diagnosis. So the healthcare provider explains that we can do a blood test and actually look at that DNA and look for those mutations that we know are responsible for cystic fibrosis. So father talks to you saying mom is telling everybody that there's just been a mistake, everything is fine. What action do we take first? So we've got he said, she said here. What's the best way to address this situation? So when we have these difficult situations and these conversations where parents are potentially not understanding a new diagnosis, best practice is to meet with them in a private environment so that we can assess the situation. We want to figure out what level of understanding that they have. And we also need to provide an area where they can express and have emotional reactions to that diagnosis without the fear of judgment. So we'll see exactly why that privacy is important with our next slide here. So the nurse meets to discuss the denial of the child's diagnosis. During the conversation, the mother finally breaks down crying and tells the nurse, I just can't believe what I've been thinking. My child is going to die, and it's all my husband's fault. I should have never married him. No one in my family has ever had this disease. My husband is adopted, and his parents do not know anything about his biological background. His biological parents must have had this nasty disease, and now he's passed it on to my baby. I'm such a terrible wife and mother for having these thoughts, but I just can't bear to watch my precious baby suffer. So, unfortunately, that is a very normal reaction to a very devastating diagnosis. So, if you could imagine that conversation happening in the middle of a hallway, that could be really scary to everybody involved to see a parent break down like this and then wonder what's going to happen to their child. Are they going to get bad news too? It's just a bad situation for everybody. So that privacy is really important so that parents can have these conversations without the fear of everybody watching them or judging them based on what's going on. Also, could you imagine if mom kept this bottled up and didn't feel comfortable telling you? And she's trying to carry all this around and care for her child. Just recipe for disaster here. So, based on what mom just told us, what response reflects that the nurse values the principle of beneficence? Great job, guys. We first and foremost want to acknowledge what the patient is expressing to us, and then we can offer to help. What does it mean to value beneficence? What does beneficence mean?
Is it along the line of like what's beneficial to the patient?
Yeah, we're trying to do good. We're trying to look for the patient's best outcome here. So we are putting their needs first here. So mom shares with the nurse that she's thinking about separating from her husband for a little while. She states that because her child has been diagnosed with CF, she thinks she may want out of the marriage. Shortly after this conversation, the nurse walks down the hall and the father asks to speak with her in private. He tells the nurse, I saw you speaking with my wife earlier. I think she's going to leave me and I'm so scared. How do we respond to that? What is our best option? Think back to that earlier question where we were playing a game of telephone. So, in this situation, our patient's family is experiencing a crisis, and we need to help them start the process of resolving that crisis. So, in this particular instance, a therapeutic response is not our best choice. When we have a diagnosis that has long term impacts, we need to allow the parents time to express emotions and work through these feelings naturally. Parents are more likely to leave the room to deal with their crisis if they're assured that their child is not going to be alone. So knowing that their child is in safe hands, well taken care of, they are likely to take a minute to take care of themselves instead of putting their child's needs above their own. By refusing to discuss with either party what the other one said, you're kind of breaking that therapeutic relationship that you had. So if somebody said, ethically, I can't tell you what she said, that kind of breaks that therapeutic relationship that you have, and you may have difficulty communicating with that parent moving forward. It casts a little bit of judgment there. Even though it is true, it's still not addressing that problem for our family. So the nurse arranges a sit down to explain the genesis of cystic fibrosis. The nurse addresses the parent's concerns about how the child inherited the disease. The nurse explains that neither parent is to be blamed, and that almost 21% of our kids diagnosed with CF are diagnosed at an older age, so between 2 and 15. We also work to identify multiple nursing problems because of the complex nature of the disease. And we work with the team leader to formulate our plan of care. The nurse recognizes the energy needs are increased as a result of malabsorption of nutrients, and that extra effort is needed for respirations and frequent pulmonary infections. The nurse teaches parents about pancreatic replacement enzymes. Which statement by the parents would indicate a correct understanding? So what do we know about pancreatic enzymes? Great job. So our enzymes are needed to digest our fat and proteins, and our body lacks the ability to excrete those enzymes. So we have to replace them in a supplemental form. They have to take them for life with each meal and snack so that we have the best chance of digesting that. Also, remember that we have a deficiency in those fat soluble vitamins. So A, D, E, and K also have to be replaced. The nurse also notes ineffective airway clearance due to excessive pulmonary secretions as one of our nursing problems, which is an expected outcome of that nursing problem. So how would we know that we have solved this problem of ineffective airway clearance due to excessive pulmonary secretions? So our nursing problem was ineffective airway clearance due to excessive pulmonary secretions. So by our patient being able to remove mucus from their airway by coughing, we know that they're able to resolve that problem on their own. So that would tell us that our interventions were effective. They are making progress towards the intended outcome here. If we were evaluating impaired gas exchange, that would be a reason to look at oxygen saturations. If we were testing parents' knowledge or trying to assess for a knowledge deficit, we would ask them to list symptoms that require a call to the healthcare provider. If we were evaluating activity intolerance, we would know that our patient is not experiencing activity intolerance if they're resting comfortably in doing those age-appropriate activities. So all of those apply to cystic fibrosis, but only the coughing is an example of airway clearance. So now we run into some legal issues. The nurse is a preceptor for a student nurse from the local community college. The student nurse asks the preceptor, I keep hearing about standards of care. What are standards of care? So how do we respond? What's the best explanation of those? So the best explanation of our standards of care, they are set by professional associations and they describe the level of care that can be expected from nurses. So nurses as a whole, no matter where I am, are expected to do a certain list of things. So it tells us across the entire profession what we can expect from nurses. They're not independent of depending on where you live. Each state is the same. We're talking about nursing as a profession, not based on location. And they don't address ethical issues. They're not included in the Nursing Practice Acts because they are universal across all nurses within the profession. The nurse shares with the student nurse that the Society of Pediatric Nurses standards of care include primary, secondary, and tertiary nursing care prevention. The student nurse asks, what type of care is given in our secondary nursing care prevention? So which statement is correct? What is our secondary prevention? So our secondary prevention aims to identify and treat disease in its earliest stages before it becomes more serious. So these are going to be things like routine medical checkups, cancer screenings, managing chronic conditions. So in this particular example, by doing that sweat test and DNA test, we're able to diagnose this child's cystic fibrosis before we have any severe complications. If we were looking at primary prevention, we would be focused on health promotion and preventing disease or injury. So that's going to be things like immunizations, lifestyle education, screening tests to detect those early risk factors. And then tertiary prevention is caring for people that already have a disability or chronic disease with the goal of improving their quality of life, managing their symptoms, preventing those complications, and slowing disease progression. So that's going to be things like rehabilitation services, pain management, end of life care. So moving on to that education piece. So we call in our clinical nurse specialist to provide intensive training for our parents. The CNS explains that she will be helping them by discussing what it means to have a child with CF, the medications and care that the client will require after discharge, and what signs and symptoms warrant a call to the healthcare provider. The nurse educator further explains that even though CF is incurable, the life expectancy has dramatically increased, and kids can live to 40 and longer now. And the key to improving the child's life expectancy is good management of the client's nutrition and pulmonary care. So, which statement by the parents indicates a correct understanding of a proper nutritional protocol for a CF patient? So, our patients with CF need a diet that is high in calories, protein, and fat. They also need additional salt because they're losing more of it through their sweat. We have to give those enzymes with each meal no more than 30 minutes in advance so that we make sure the food and the enzymes hit the small intestine at the same time. They also need supplemental vitamins A, D, E, and K. Those are fat soluble vitamins that they struggle with absorbing. And because they have such a high caloric intake, remember we need them to have 150% of the calories that you and I do. That's a lot of food to eat. And it can be overwhelming to try and consume that much food. So we try and break it up into 3 meals and 2 to 3 snacks a day so that we're not overwhelming them with how much they have to eat. And also, preventing their stomach from getting so full and putting pressure on their diaphragm and competing with their lungs being able to expand appropriately. Parents wish to learn everything they can about CF, which indication or which action indicates that parents need more instruction about the respiratory care. So, which action indicates parents need more understanding, need more instruction? So, we're looking for what is the wrong thing here. So, we know that patients that are having difficulty breathing need to be placed in a position that maximizes their ventilation and their airway patency. So, ideally, we would place this child upright, not flat on their stomach when they're having difficulty breathing, so that they can cough, clear their airway. We tend to see cystic fibrosis patients, just like our COPD patients, they tend to get into that tripod position to have easy work of breathing or to maximize the effectiveness of their breathing. When we are doing chest percussion and postural drainage, we are loosening up all that mucus and it's starting to move around. That causes us to kind of lose our appetite for a little while. So we need to make sure that we have a long break in between our chest percussion and when we're offering a meal. With all that mucus flowing around, we're probably not going to have much of an appetite for a little bit. Also, if we do it immediately following a meal, we can increase our risk for vomiting. And we know that exercising helps loosen up our mucus and stimulating us to cough. So, research shows that children with CF who regularly participate in aerobic exercise, like jogging and swimming, tend to have fewer pulmonary complications. So, we know that's a true statement. And nebulized medications help loosen secretions and make them easier to move from those small airways into the big ones so that we can cough them out. So we want to make sure that we are doing that chest percussion after we give those bronchodilators and nebulized medications so that we can promote that airway clearance. Chronic respiratory infections are a major cause of lung damage in CF. Mobilizing secretions is important for these patients. What actions address those chronic respiratory infections and mobilizing secretions? So, what action addresses those chronic respiratory infections and being able to mobilize secretions? So we know we need those breaks between chest physiotherapy and meals to reduce our GI distress. We want to give those aerosolized medications before our chest physiotherapy so that we can open those airways to make it easier to get stuff out. We hold off on steroids for acute exacerbations because they don't work very well for our cystic fibrosis patients. They don't provide a lot of relief and they have a lot of side effects to them. They also don't have anything to do with mobilizing secretions. Same thing with oxygen therapy. We're going to reserve that for when we have a patient experiencing hypoxemia. With chronic lung disease, long-term oxygen use can cause them to retain carbon dioxide. So that would make it worse. And just like we talked about with Eliza Simmons when she didn't want to do her incentive spirometer, those fun activities that encourage deep breathing can be things like blowing bubbles, pinwheels, blowing a ping pong ball or cotton ball across the table, blowing up a balloon, any fun activity that gets you to take a deep breath. Parents are worried about their child meeting her nutritional needs. The nurse educator explains that the thick mucus blocks the pancreatic ducts, preventing enzymes such as trypsin, amylase, and lipase from being secreted into our small intestine. So, what instructions do we give to the parents concerning the use of pancreatic enzymes as an oral prescription? What directions do we include? Yep, we want those enzymes to be given no more than 30 minutes before a meal. For infants, we can mix the enzymes into either cereal or applesauce or formula. Um, with our patient being 2, swallowing that capsule whole puts her at risk for aspiration. So ideally for these patients, for our young patients, we open up that capsule and we sprinkle those beads onto the first couple bites of food that they take. Okay, let's get one more question in before we go on a break. Our CNS explains the dosage of pancreatic enzymes is adjusted according to stool formation. Which adjustment is going to be required for constipation? So think about what the purpose of our pancreatic enzymes are. What do they do to our stool? Nice work, guys. So the purpose of our pancreatic enzymes is to decrease the bulk of our stool. Um, they help us digest our food better, so we have less to excrete in the stool. So if we increase the amount of pancreatic enzymes, we're going to decrease the amount of stool that we have. Okay, we are going to go ahead and take a break now. Our case study here. So we're going to move into those psychosocial aspects of care and those community resources that are available. So our CNS is back in the picture, and she refers the parent to the local chapter of the Cystic Fibrosis Foundation. What rationale best supports that referral? Why would we want to refer them to a local chapter of our Cystic Fibrosis Foundation? Yep. So our Cystic Fibrosis Foundation has chapters throughout the US, and their goal is to provide education and services to both patients and professionals. They provide support and factual information, allowing parents to get together with other parents that have experienced that similar situation to be a sounding board, provide help and encouragement, hope, and give them that support system so they don't feel so alone. If the client attends a daycare, what do the daycare workers need to know to keep her safe? So if we have cystic fibrosis, what needs to be shared with those daycare workers to keep our child safe during the day? We know kids with CF are more susceptible to infections, so the best way to prevent the spread of infection is through proper hand hygiene. Also, keeping them away from kids that have other upper respiratory infections is going to be helpful in keeping them safe. They need their pancreatic enzymes with every meal and snack, not just twice a day. Ideally, we want to give it with a non-starchy food. And we need to know the correct techniques for chest physiotherapy so that we can prevent those respiratory infections, help them clear their airway. And they will actually get their vitamins twice a day to help them absorb them better. So, unfortunately, cystic fibrosis is one of those lifelong diseases and it requires full time ongoing care. One of the ways that we can help support parents is by offering help in searching for a daycare facility or a home daycare setting that would give them some respite care to take care of family matters without having to worry about their child. On the day of discharge, the CNS discusses routine immunizations. What is the nurse's responsibility when discussing immunizations? So, what is our role in that conversation? What's our scope of practice? What do we know about immunizations and cystic fibrosis? We know the importance of immunizations to protect us against those infections and diseases that could exacerbate our CHF. Um, we don't have to get the physician involved. We are totally capable of providing information about immunizations. And we actually don't need to delay immunizations just because we have cystic fibrosis. The only reason that we would delay immunizations is if we were on long-term steroid therapy, which we already said we don't use in these patients, or if we were immunocompromised. So just because we have CF doesn't mean we have a compromised immune system. The CNS asks which immunizations the client has already received and notices that the child has not had a second MMR vaccine. When do we give that second MMR vaccine? So our MMR vaccines are given at 12 to 15 months of age, and then that second dose is given between 4 and 6 years of age. So it matches up with several of our immunizations. So if you have to take a guess at when those doses are due, 1 year of age is typically that first dose. That second one hits right before they start kindergarten. So now we have a complication. Our patient goes home, they're doing great with their follow-up. They've gotten in contact with support groups and speaking with counselors. They're able to care for their child well. 1 year after being discharged, the client is brought into the emergency room. Father reports that she started coughing, choking, and was unable to catch her breath. She passed out briefly, so he put her in the car and drove straight to the hospital. When they get to the hospital, she's alert and oriented times 3, is lethargic, sitting in a tripod position. At this point, she would be about 3 years old, weighing 12 kilograms or 26.5 pounds. Vitals are a temperature of 99, heart rate is 110, respirations are 22, and she's satting 91%. She is retracting, flaring, and grunting. So what intervention do we implement first? Based on her presentation. You guys got it. We're starting with those ABCs. We put this patient on oxygen. She is hypoxic. We have told you all along that 90% is our cutoff for pediatric patients. I will tell you that HESI is different. So HESI wants them to be above 95 to be considered normal. So that is different from your textbook. So just tuck that away in your brain that for HESI, we want oxygen saturations to be above 95 for our pediatric patients. I don't tell you that until now, so I don't confuse you on exams. Which lab results would warrant immediate intervention? So what would tell us we have a problem that could cause a CF exacerbation? So the only abnormal lab result presented here is our white blood cell count, and it is elevated. So that indicates that we have a potential infection brewing. Otherwise, these are normal lab results. This is why we have to read those questions very carefully. Everybody sees chloride level and they see a high number and they know we're talking about cystic fibrosis. So they get really excited because they know that we test chloride for cystic fibrosis diagnosis. But we skipped over the key word at the beginning of that answer. We are talking about a serum chloride level here. So because that word serum is there, it means we're talking about the level of chloride in your blood. So that is actually a normal value for the chloride in your blood. If it said we had a sweat chloride level of 101, yes, that would tell us that we have cystic fibrosis. But we already knew that for this patient. So that wouldn't tell us that we had a new diagnosis here. That elevated white blood cell count tells us about infection, which could cause a problem for our CF patients. So 2 days later, the clients, oh, sorry, I guess I need to fill in the backstory here. Because of this infection, our healthcare provider diagnoses us with pneumonia and starts us on gentamicin every 8 hours over 30 minutes, and also orders those routine peak and trough levels. Pharmacy sends up our medication and we start administering it. 2 days later, we have an improvement in our condition, but we're still in the hospital for continued antibiotic therapy. The primary nurse reports to the charge nurse that the IV antibiotic ordered was administered to another child, and the client received the other child's ordered antibiotic. So we mixed up our meds here. When the primary nurse realized the mistake, the IV antibiotic was discontinued immediately. What action should the primary nurse implement first? So we mixed up our medications, we gave it to the wrong patient. What do we do first? We need to assess our patient first to make sure nothing bad happened immediately. We also need to know what to tell our healthcare provider. So if we don't do that assessment first, if he asks us any questions about our patient, we won't necessarily know the answer because we haven't laid eyes on them yet. So we would assess our patient, making sure they're safe from any adverse effects. Then we can notify our healthcare provider of what happened and receive any follow up instructions. We may or may not give that correct antibiotic depending on what the mix up was. Um, so we need to talk to our physician to make that decision. And then the final step is going to be completion of that incident report after everybody is all taken care of. Our primary nurse, who is assigned 4 clients, is working with an unlicensed assistive personnel overnight. What tasks can be delegated to that person? Nice work. So anything involving assessments or medications has to be completed by a nurse. So the only thing that an unlicensed personnel can do is take vital signs. So even discontinuing an IV requires us to assess that site. The primary nurse asks the RN leader if it is okay to interrupt the child and play therapist for vitals. What action should the charge nurse take? So, can we interrupt therapy for vital signs? So, therapy is an equally important part of hospitalization. So, the only time we interrupt therapy is for an emergency situation. So, in this particular instance, we can wait to take those vital signs until therapy is over. If the patient was due for vitals, I would make sure that I walked by the room and laid eyes on the child just to get an observation of them, making sure there wasn't an emergency situation. And then we can just wait until therapy's over for those vital signs. So our client's pneumonia resolves, the CNS visits with the client and the parents one last time. They share they're excited to go to the beach this summer on vacation, And they ask the nurse educator if any special precautions will be necessary for that beach vacation. So how do we respond? What precautions will our CF child need for a beach vacation? So hot weather can cause a CF exacerbation. The increased risk for electrolyte imbalance because of dehydration, also that increased sweating. So we want to drink plenty of fluids always when we have cystic fibrosis, but especially during those hot, humid summer months. We also want to increase our salt intake because we're going to lose more of it the more that we sweat. So as long as we are preventing dehydration and adding that extra salt, there's no reason that our patient can't go to the beach. We don't need to severely limit the time that she can be at the beach as long as we are offering those fluids and keeping sunscreen on her to protect her from burns that could worsen that dehydration. So overall, our patient gets discharged home. The CNS sends home a number for a CF clinic near the beach in case they have an emergency while they're away. So now parents are confident planning that first vacation. So wrapping up cystic fibrosis here, we've got a lifelong multi-system disorder that really affects quality of life. So we've got those airway issues. We can have sterility. We can have issues with digestion because of that pancreatic dysfunction. So we have to do everything in our power to maximize their quality of life, help them work through making decisions, dealing with potential legal issues, end of life decisions if need be. Sometimes we can help these patients by transplantation, so helping them work through that process. So lots and lots of opportunities to support these patients as they work through this journey. They will be in and out of the hospital a lot during this time. What questions do you guys have about anything we covered with cystic fibrosis? Okay. We will switch gears to our Kahoot here. Okay, guys, the pin is in the chat if you need to join us after we start, but we'll go ahead and start now. So with epistaxis, we want our patients to sit and lean forward and pinch that soft portion of their nose to control the bleeding. If we have them tilt their head backwards, all that blood is going to run down the back of their throat and make them cough and try and clear their throat. For infants with hip dysplasia, we place them in a Pavlik harness to keep that hip in proper alignment. So after a tonsillectomy, we want to stay on top of that pain. So administering frequent pain medicine. We can also use ice to help alleviate pain and swelling. And then by giving them gum, we can help stimulate those digestive juices to start flowing again and hopefully restart their GI tract after surgery a little bit quicker. An oxygen tent or a mist tent. Those are those plastic boxes that we put over top of their head to either give oxygen or humidity. Those need to have a flow rate of 12 to 15 liters a minute. So we make sure we have enough air circulating and we're not just sitting there suffocating our patients. With pyloric stenosis, we did our CJ Sim and our discussion question on this. The main symptom that we see is that projectile vomiting across the room. The leading cause of childhood poisoning is going to be medications. Which medication is most common?
Acetaminophen.
Yep, acetaminophen, our everyday Tylenol, readily available. Propylthiouracil. What is its indication for hyperthyroidism? So even if you've never heard of that medication before, we know what hyperthyroidism is. We know that means we have too much thyroid hormone. So if we were giving a medication because we had too much thyroid hormone, we would expect it to decrease that production to help return it to normal. Anabolic steroid side effects can include high blood pressure, jaundice, acne, increased risk of cancer, and all of these as well. So we see effects on our reproductive system, our behavior. We can get violent mood swings and increased aggressiveness. Which medication would we question for a patient with epistaxis? So those are our nosebleeds again. So why would we question aspirin?
Because it increases bleeding.
Yep, it interferes with our platelets, which help us clot. So we would question that because it would increase our risk for bleeding. We have not identified a single known cause of autism. There are lots of factors that play into that diagnosis, something we are still learning about. So with hip dysplasia, we've got one hip that's out of that socket. So we'll see one leg being shorter than the other. We might see a little asymmetry in our buttocks. So one cheek's going to be a little bit lower than the other one. Rheumatic fever is caused by that strep throat infection. So with respiratory distress syndrome in our infants, we obviously want to maintain their airway. So clear any secretions by suctioning, giving them oxygen as needed. We also need to keep them nice and warm, a nice neutral temperature there. If they get too cold, they can sometimes have apnea, where they forget to breathe. If they get too hot, they tend to get tachypnic, so they'll start breathing really, really fast, fast and shallow when they're hot. We want to minimize that environmental stimulation going on so that they can focus strictly on breathing. So we want their focus to be on breathing, not on interpreting everything going on around them. Our knee chest position in our tetralogy patients helps increase our blood flow to the lungs, helps to reverse that shunt that we see across the VSD. So we get more going to our lungs to be oxygenated. Effective education about head lice, making sure that we are getting rid of all those nits and those parasites by washing anything soft in hot soapy water. The entire family doesn't need to use a medicated shampoo if they are not infected. So only the infected person has to be treated for head lice. Oxygen saturations in the 60s and cyanosis tells us that our child is experiencing that TET spell. Your first action is always, always, always to place that child in that knee chest position. If we don't reverse that shunt, that child is not going to be able to use that supplemental oxygen. So you've got to get their knees up first, then you can apply oxygen. So always, always, always with tetralogy, knee chest position is always going to be your first action. So folic acid, we know helps with sickle cell disease because it makes new red blood cells. So if we were trying to do a process of elimination here, we got to look at sickle cell disease. We know it's talking about our red blood cells. So that gets us down to our blue and our green answer. So which of those two is the better answer? Well, red blood cell production, folic acid wouldn't interfere with our RNA and our DNA. Interfering with that wouldn't help make new red blood cells. So just the fact that folic acid helps to make our new red blood cells is the best answer here. Perfect. Our urine output, our diaper weights. 1 gram of diaper weight is the same as 1 milliliter of output, that lovely 1-to-1 ratio. All of these are going to be signs and symptoms of a patient with acute myeloid leukemia, except for polyuria. So with leukemias or any type of cancer, we expect to see fevers, infections, petechiae. Polyuria is going to be associated with one of our diabetes. So whether it be diabetes mellitus or insipidus. Parallel play is our 2 to 3-year-olds. That's that initial stage of play where we're playing in close proximity, but doing our own thing. Our VSD is a hole between the lower two chambers of our heart. So it creates that left to right shunt that leads to excessive pulmonary blood flow and pulmonary artery pressure. So the more flow and pressure you have in an area, that's going to cause hypertension. So we're going to see pulmonary hypertension here. This should look very familiar with our sweat chloride test to diagnose cystic fibrosis. We are looking at sodium and chloride. The other name for Alboset is amphotericin B. We know that's one of our common antifungal medications. Medication that is twofold to treat acne and sinus infections is going to be doxycycline. When we have a medication that ends in LOL, what type of medication is that? What medication class?
Isn't it for like blood pressure?
Yeah, it's going to be a blood pressure medication. Typically our beta blockers. So that has nothing to do with our thyroid hormone. So this one is false. It's that propylthiouracil that we saw earlier. Our treatment of Lyme disease can cause soreness of our muscles. So, diagnosis of hip dysplasia on that newborn assessment, when you see the physician kind of moving their legs in and out when he's doing that assessment, that's that Ortolani maneuver. So, as we're doing that movement with the infant's hips, we can hear a clicking sound or we can feel that click as that hip joint moves in and out of socket. We can see one leg being longer than the other and those asymmetrical folds in our buttocks as well. Lyme disease is carried by those ticks. Transmitted from person to person. All of these are required immunizations for grade school. So we need our varicella vaccine, our chickenpox, our DTaP, our polio, and our MMR. Let's get one more question in here. Signs and symptoms that are common in the initial phase of leukemia. So typically before we have a leukemia diagnosis, these patients will have a consistent low-grade fever, so just above normal, and parents can't find a rhyme or reason for that elevated temperature. So that consistent low-grade fever is usually that initial sign of leukemia. So we are going to stop there for today. Congratulations to our winner here. We're going to take a peek at what is going on for end of term. So next week is HESI for us. To help you get ready, you have 3 different sets of practice questions. So you have your 2 HESI assignments, your practice exam and your assignment exam. Those are 2 separate assignments, and you need to use these links in Canvas so that your grade transfers to the grade book correctly. So if you don't use each of those links, then your grade will not transfer correctly. So make sure you use both links that are there in Canvas for you. There is nothing for you to actually submit. Your grade transfers automatically, so you don't actually have to submit anything. There may be a slight delay in the time that it takes for you to finish the assignment and your grade to reach Canvas. So don't be surprised if there's a little bit of a delay there. On both of those, your first attempt is the grade that is recorded. So when you sit down to do those, make sure you are ready for them because those are part of your homework grade. You also have one final set of NCLEX questions going over those last body systems that we covered in class. So make sure you're submitting that PDF report that has all of the different question subjects, tells me how many you attempted, how many you got correct. I need that full printout report in order to give you credit for your assignment. We still have 2 opportunities for live HESI reviews. So Saturday, tomorrow at 2 p.m. Eastern Time, Professor Bogart is doing her joint RN and PN pediatric review. So everybody taking peds within the Fortis institution will be there in attendance. She is phenomenal when it comes to working through critical thinking skills, how to answer these application type questions. So please, 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 please set multiple alarms for that review session tomorrow at 2 p.m. Make sure that you do not miss that one. Students that attend that review session tend to do a lot better on their HESI than their peers that did not go to it. So once you open your course calendar, all you have to do is click on that event on your calendar and you have a direct link to her Zoom from there. Your last chance for a live HESI review is on Sunday, the 16th at 4 p.m. Eastern Time with Professor Luminoso. So great time to get last minute questions answered before you guys sit down for your HESI next week. Next week is our HESI, so we will not have class together. You will not see me next week unless you schedule a meeting with me to review. Once I see that you have completed your HESI and you have a score, that is what grants you attendance for week 11. So the campus is handling scheduling of HESI exams based on room and proctor availability. So if you have not gotten your assigned date and time from your campus yet, then I would reach out to them as soon as possible. And if you have questions with registering for your HESI online, make sure to reach out to the campus so that they can help walk you through that process. As soon as you are finished with your HESI, everybody is required to remediate, no matter what your score is. So even if you get a perfect score on your HESI, you still have to do 1 hour of remediation. So this just helps solidify some of those missed concepts so that next time you see them, you will answer those questions correctly. So it helps you find those areas of weakness, room for improvement. So everybody is required to remediate no matter their score. If you choose not to remediate, you end up with a 0 on your HESI and you will fail the class. So your HESI is 20% of your grade. That will cause you to fail. The other reason that we want you to do your remediation is because your classmates are waiting on you for their final grades. So I can't release final grades to anybody until the entire class has completed their remediation. So your classmates are waiting on you to finish your remediation so that they can get their final grade. So even if you happen to be unsuccessful, which I don't think you will be, but if you happen to be unsuccessful on the HESI, please still do your remediation so that you're not holding up your classmates' final grades. Also, should you need to submit an appeal for this class and you choose not to do your remediation, the appeals committee does not look fondly on that. It shows that you are not putting forth effort and not trying to learn about these conditions in these patients. So they are likely to deny your appeal because you chose not to do your remediation. The hours required will be in an announcement for you next week. So tomorrow when the announcements come out, that will be included for you to be able to find very quickly. So no class next week. I am available to meet with you if you have last minute questions or need to review information. So just let me know what works for your schedule, and we can definitely meet together to help you get ready. Please make sure that you come back to me in week 12. This is for your benefit. We will be having a very short and sweet class, just making sure that I didn't make any mistakes and that you do your course evaluation. It is important that you show up at some point during week 12 to protect your attendance. If you miss week 12 with me, and maybe you have a scheduling snafu or something in week 1 of the next term, if you miss both of those weeks, you can be dropped for 14 days of non-attendance. So there's no reason not to meet with me in week 12. I just have to see you at some point between Monday and Friday during that week. So with you guys being a Friday class, if you do not want to wait until Friday night to pop in for your attendance, then you are more than welcome to attend any of my other classes. So I teach Monday morning. No, I don't teach Monday morning anymore. Tuesday morning at 9 a.m. I teach Wednesday evening at 5:30 p.m. Or I also have a Friday morning class at 9 a.m. So you are more than welcome to attend one of those classes so that you don't have to wait until 5:30 on Friday night for your attendance. You can also set up an individual appointment with me if those times don't work for your schedule and you don't want to wait for Friday night. As you guys are studying, if you look in your announcements, you have a weekly HESI review sessions announcement. And within that are all of the recordings and PowerPoints from your HESI review book broken down by body system. So as you are doing practice questions, this is a great resource to brush up on information. So the best course of action over this next week as you guys are preparing for HESI is doing multiple rounds of practice questions. Using those test taking strategies, practicing applying those to those questions, even the easy ones, just so that you get in the habit of doing it. If you identify areas of weakness where you're consistently missing questions on a specific subject, use this announcement to go back and brush up on information. Easy way to pinpoint that information that you need to review. Then do another round of practice questions. See if you notice improvement. Keep repeating that cycle over and over again. It takes the anxiety out of test taking. It becomes second nature to you to go through this process. So that is the best way to study for HESI. That is the best way to study for boards. That is my recommendation to students. If you are struggling, please reach out for help. I am more than happy to meet with you guys throughout the week next week. We can either email, text, we can jump on Zoom if we need to. What questions do you guys have about end of term